Cardiovascular assessment, your normal anatomy and physiology. The heart is the size of a closed fist. Males have slightly larger hearts. The pericardium has two layers. You've got your fibrous connection and your visceral connection. Connection meaning layer. In between the two, there's a 20 to 25 milliliters of fluid, epicardial fluid, that's contained within. Now, to decrease friction, the pericardium has two layers, which I've already said. The epicardium is also known as the visceral pericardium, and it is closely adhered to the heart. Underneath it, there may be a fat layer, and that fat layer can cover up to 80% of the heart. The thicker the fat layer, or the more of it you have, the greater your risk of coronary artery disease. And it can make up about 20% of the heart's weight. The myocardium is your muscle layer, and then your endocardium is the innermost layer. This is the layer that's made up of endothelium, and the endothelium is the inner lining of all your blood vessels, your heart, and it also covers, is used to form the valves for the heart. Your endothelium can cover 3 football fields if it's laid end to end. The heart has 4 chambers, 2 atria, basically collection chambers. So the pressure in them is very low. They're very thin-walled. 80% of your atrial blood supply drops automatically into the ventricles. This is called your atrial. Then when the atria contract, you get what's called an atrial kick. When the heart develops an atrial dysrhythmia, this atrial kick is lost, and the cardiac output is decreased by up to 20%. You have 2 ventricles. Because the right side only has to pump as far as the lungs, it's only about 3 millimeters thick. The left side, because it has to pump everywhere from the top of your head to the bottom of your feet, is about 13 millimeters thick. So that if you look at a picture of the heart, you can just, a cross-section, you can see by just looking at it which chamber is which because of the thickness. You don't really need to have it labeled. There are 4 valves. You have your atrioventricular valves that are held in place by chordae tendineae and papillary muscles. The tricuspid valve is on the right. It starts with a TR, so it means it's on the right, and it's located between the atria and the ventricles. The mitral valve is located on the left. It ends in L, so it's on the left. It's also between the atria and ventricles, but on the left. The aortic valve on the left is on the left, and the pulmonic valve is on the right, and those are at the exit of the ventricles. Normal conduction of the heart, the electrical system is there to make sure that it contracts in a rhythmic fashion. You have your SA node. It receives the blood supply from the right coronary artery, and the right coronary artery does this in about 66% of all people. The SA node gets it from the left coronary artery in the remaining 34% of the people. The SA node has an intrinsic heart rate of 60 to 100. The SA node sends an impulse by way of the internodal pathways. There are 3 on the right and 1 on the left. The one on the left is Bachmann's bundle, but you don't need to remember that. They go to the AV node, and the AV node will slow conduction by 0.8 to 1.2 seconds. This AV node will also control the number of impulses that get through the ventricles. It has an intrinsic heart rate of 40 to 60. It also allows for retrograde conduction of both the SA and if both the SA and AV nodes fail. 90% of the blood to the AV node is received from the right coronary artery, and 10% of the people is from the left coronary artery. There are 2 bundle branches, because it goes from the AV node to the bundle of His to the bundle branches. And then down the bundle branches, there's 1 on the right and 2 on the left, to the Purkinje fibers. Now, on the left, the branches are called the anterior and the posterior. Then from the Purkinje fibers, it goes to the ventricular cells, and the intrinsic heart rate of the ventricles is less than 40. The right coronary artery supplies the right atrium and the ventricle, and 70% of the posterior portion of the heart. The left coronary artery splits into the left anterior descending and the circumflex almost immediately. The left anterior descending supplies the left atrium and the ventricle. The coronary veins empty into the coronary sinus and then into the right atrium. Now there is a normal physiologic cardiac shunt. The thespian veins connect the capillary beds with the cardiac chambers by way of a small sinuses within the myocardium. So that will cause a small amount of deoxygenated blood into the left ventricle. This also occurs if you have ventricular septal defect. The aorta contains coronary ostia and the sinus of Valsalva immediately above the aortic valve. So the heart gets the best oxygenated blood. And remember, the heart gets its blood supply during diastole, not during systole like everything else. Because during systole, you've got your muscle contraction, which is pushing on those arteries, and so they cannot fill. You have to wait until diastole for that to occur. You then have your pulmonary artery and your pulmonary veins. Pulmonary arteries exiting the heart, because arteries leave the heart, and your pulmonary vein, which comes back to the heart. Now that pulmonary vein may also contain a small amount of atrial tissue, and that atrial tissue can cause atrial fib in some patients. You have your systemic circulation. Now remember, your arteries, just like your heart, has 3 layers. You've got your adventitial layer, which is your outermost layer. It is made up of connective tissue. Then you've got your medial layer, which is your muscle layer. It's the middle layer. And the intima, which again is made of endothelium. But because it's made of endothelium, it decreases resistance to blood flow and it decreases platelet aggregation. So there's fewer clots that can occur there. Some terms you need to know: your blood pressure. Your systolic blood pressure is your left ventricular volume that's ejected. You can also think of it as afterload. Your diastolic blood pressure is what occurs during the resting state. It's the pressure that's there when the heart's at rest. Your pulse pressure is your systolic blood pressure minus your diastolic blood pressure, and the normal is at least 40. Your mean arterial pressure is your systolic blood pressure plus twice your diastolic blood pressure, and that total divided by 3. And you need to have that around at least 60 to make sure things are perfused appropriately. Your systemic vascular resistance is your opposition to blood flow. It's caused by changes in your vascular tone. It's abbreviated as SVR. Your pulmonary vascular resistance is the vascular tone in the lungs and can be called PVR, but don't confuse that with peripheral vascular resistance. There's a diagram on page 295 of the blood and the different storage sites for the blood. The venous system contains your veins. Veins are considered capacitance vessels because they can expand to hold a lot of fluid, particularly in your spleen, your liver, and your intestines. Your veins at any one time contain about 75% of your blood supply. Your history, you need to get, when you assess your patient, the history of their assessment of what has occurred to them. And you'll find a box on page 308 of questions that you should ask when you're getting your data collection. And remember, when you're asking questions, your pain scale should always start with 0, because our goal as the nurse is to have no pain. So you never start with 1. It's 0 to 10, 0 to 5, 0 to 3098. Whatever numbers that you use, it always starts with none. You need to know your symptoms and include your associated symptoms such as nausea, vomiting, any radiation of that pain, or diaphoresis. You need to know your patient's profile, their age, their sex, their weight, their health habits. What's their support system like if they have one? Any cultural information, because that will make a difference as to how they respond to different things. Their emotional status, their perception of the illness. In other words, do they see this as a gift from God, or is this a problem? Then you need to look at the risk factors, and I like to divide them up into 3 categories. Those that you cannot change, those you can change or treat, or those that are preventable. So those that are non-modifiable, things you cannot change, is your sex. Even if you have the surgery to have the sex change, you're born, your internal body is the same regardless. So if you were born a male, that's what you're going to be. Your age, your cultural identity, and your family history. Anybody who has someone in their family who's had a heart attack before the age of 65, it becomes a risk for them, and you can't change that. Those that are modifiable or treatable are things like hypertension, diabetes, hyperlipidemia, dysrhythmias, obesity. Those that are preventable are smoking, sedentary lifestyle, your diet, and some people put obesity here also. So they do tend to blur a little bit. Your family history, again, before the age of 65, did they have a heart attack or a stroke? Did they have a history of hypertension, diabetes, coronary artery disease, or collagen vascular disorders? Because that would indicate that you might have a collagen vascular disorder that would promote clotting. What are their prior medical tests? Have they had a cardiac cath? Have they had an echo? Have they had any blood work within the last 6 months? Many times insurances will only pay to have certain tests done every 6 months or longer. So you need to know that. You need to know their medical history. Do they know if they have a murmur, a strep infection, rheumatic fever, any prior surgeries, any medical conditions? For example, do they have a permanent pacemaker in place or an implantable cardioverter defibrillator? Have they had bypass surgery? Do they have a ventricular assist device in place? What are their allergies? Have they had recent dental work? That particularly comes in play with different types of cardiomyopathy. Their current medications. Are they on anticoagulants, antihypertensive medications, antidysrhythmics or antiarrhythmics, digitalis, nitrates, diuretics, hormone replacement therapy, antiplatelets, beta or calcium channel blockers, herbal drugs, statins, and that's just to name a few. You need to know what they all are. On your physical exam, you need to inspect them. Look at them. What's their weight, their posture, their color? You want to check under their tongue and in the sublingual area for central cyanosis, because this is the most sensitive measure of cyanosis. And if they're cyanotic here, you need to do something about it right away. In other words, you need to start them on some supplemental O2. You need to see if there's any neck vein distension or jugular vein distension. Particularly, you look at the end of exhalation and you look with the head of the bed elevated 30 to 45 degrees, never when it's flat. And there's a picture on page 311 that talks about the abdominal jugular reflex and how when you push on the abdomen, you can see whether or not the neck veins distend, which would occur if they had somebody with excess fluid volume. You need to look at your thoracic reference points, like your point of maximal impulse, which is at the mid-clavicular fifth intercostal space, and this is the point at which the heart is closest to the chest wall, and you should actually see a pulsation there, particularly if it's somebody who's very thin, or you can palpate it there. It's also the point at which you listen for your mitral valve. You want to look at their extremities. Remember, one of the symptoms that occurs when you don't have a sufficient amount of blood supply to the tissues is that they lose the hair that's on your fingers and toes. Yes, ladies, you are supposed to have hair on your toes, but if you're one of the ones who shave it off, just make sure that you tell your nurse that you've done that. What's the temperature of that extremity? Their skin texture, skin color. The color is kind of brownish, and they are not of a different race. If they are Caucasian, then the color is brown. That means you've got a venous problem. You've got venous stasis. Is there any edema? And we'll talk about that when we talk about palpation. Is there any clubbing of those digits? Now, to look at that, you'll find that on page 309. But your central cyanosis, as I've mentioned already, is your most sensitive measure. And you'll find that occurs if you have somebody who has COPD or hypoxia. Peripheral cyanosis is due to a decrease in cardiac output or arterial disease. It will also cause a decrease in O2 to the tissues, but it will never cause clubbing of the fingernails. So the clubbing of the fingernails is due to just not getting enough oxygen in to begin with. Your pulses for palpation, your pulses are graded 0 to 3 plus, from absent to weak to normal to bounding. If you have pulsus alternans, when you check your carotid, you'll notice that every other pulse is strong and then weak. This tends to be a bad sign. It tends to indicate that they have severe left ventricular failure. And remember to palpate low on the neck, because you don't want to palpate the carotid bodies. Those carotid bodies are in the neck and they will cause your heart rate to slow. So you never palpate both sides at the same time, and you also palpate low so you can avoid them. You check in your abdomen to see if you can find the abdominal aorta. Now normally it's the size of your thumb. If it's bigger than that, you may have an aneurysm that's there. You check for your capillary refill time. And when you're looking for capillary refill time, it should take less time for that color to come back than for you to actually say capillary refill time. It should be less than 2 seconds. There's a table on page 310 that compares your arterial and venous disease. You want to do an Allen test to evaluate flow to the hand, particularly if you're going to do arterial blood gases or put in an arterial line. There's a picture on page 313, and there's also a box that tells you how to do this. Your dorsalis and posterior tibial pulses need to be checked. Now remember that everybody has a posterior tibial pulse, but only about 90% of the population has a dorsalis pedis pulse. When you're grading edema, there's a table on page 314 that tells you how to measure it. It's usually measured as 0 to 4 plus. If you have induration or when you palpate that lasts longer than 15 seconds, it's considered pitting. Less than 15 seconds, it's considered non-pitting. But a better way than grading it from 0 to 4 plus is to measure how long it stays indurated and how deep it goes. You also are going to assess for deep vein thrombosis. Now, Hohmann sign sometimes is encouraged, sometimes is discouraged. You need to assess, find out what your hospital policy says about that. But remember, you palpate the calf of the leg while you dorsiflect the foot to see if there's any tenderness there. And Hohmann sign is not necessarily 100%. There have been patients who have had multiple pulmonary emboli and still have a negative Hohmann's. And you, again, palpate for your PMI, which is the midclavicular line, fifth intercostal space. Percussion is rarely used because you can palpate where the PMI is located to determine actually what the heart size is. So that we rarely percuss for the heart. Auscultation, you've got your blood pressure. Remember, blood pressure of 140 over 90 or greater is definitely hypertensive. Pre-hypertensive is up anything greater than 120 systolic or 80 diastolic. There's normally a difference of 5 to 10 millimeters of mercury between the right and the left arm. Left arm is usually higher. If you're using an automated cuff, remember it's only accurate for your systolic measurement because the diastolic is estimated based on your systolic. Your orthostatic hypotension is when your blood pressure stands when you, your blood pressure drops when you sit or stand up with a concomitant or along with an increase in your heart rate. And there's a box on page 315 which tells you how to do that. Heart sounds, there's a handout that I've typed up and put on the website for you to look at. There are also figures on page 317, a box on page 316, and a table on 320. Now, pulsus paradoxus is when you check your pulse while you're taking the blood pressure. Normally, your pulse should decrease the strength of that and the rate by about during inspiration and increase during expiration. Normally that change is between 2 and 4 millimeters of mercury. If it's greater than 10 millimeters of mercury, you have pulsus paradoxus. And pulsus paradoxus may indicate cardiac tamponade. The procedure for checking this is on page 316 in Erden, in your critical care book. And everything I just said about pulsus paradoxus is now written on this slide. Some of the different diagnostic procedures that are done are your electrolytes. Your potassium 3.5 to 4.5. The norms that are here are the ones from your textbook. They will vary slightly at every institution that you go to. Some of them take potassium all the way up to 5. I have not seen any institution where it drops the potassium below 3.5 and still says it's normal. Hyperkalemia could be due to rhabdomyolysis, renal failure, potassium administration, potassium-sparing diuretics such as your angiotensin receptor blockers or your ACE inhibitors. If you have somebody who's hyperkalemic, you will have tall peaked T waves on your EKG. That means your T wave is about 2/3 the height of your R wave. You'll have a widened QRS, a prolonged PR, and when your potassium goes greater than 8, you may actually have ventricular standstill or ventricular fibrillation occurring. Hypokalemia, on the other hand, is oftentimes due to GI loss, steroids, diuretics. It will cause premature ventricular contractions, VTAC, VFib, and the presence of a U wave. Calcium, normally 8.5 to 10.5. Too much of it, hypercalcemia, could be due to bone tumors, parathyroid disease, hypomagnesemia, excessive vitamin D administration. This will cause all types of AV block, bundle branch blocks, and bradycardias. It will also increase the effect of digitalis and can cause hypertension. On the monitor, you will have a short QT interval. Hypocalcemia is due to blood transfusions, shock, magnesium imbalances, alkalosis causing bradycardia to ventricular tachycardia, and possibly even asystole. These patients will have a prolonged QT interval, which puts them at risk for torsades de pointe. And we'll talk about the rhythms in the lab a little bit more often and go over those again. Hypermagnesemia, your magnesium levels normally 1.5 to 2. Hyper is due to renal insufficiency, maybe over-treatment. It's very rare. It can also be due to your tumor lysis syndrome. Hypomagnesemia, on the other hand, must be corrected before you can correct hypokalemia or hypocalcemia. They won't respond to anything that you give them if you don't correct your magnesium level first. And that low magnesium level could be due to TPN, insufficient intake, chronic alcohol abuse, diuresis, diarrhea causing hypertension, vasospasm. On the ECG, you'll have a prolonged PR and a prolonged QT. You may have U waves or a flat T wave. You'll have a wide QRS. You may develop a supraventricular tachycardia or torsade de pointe. And torsade de pointe, of course, is a type of ventricular tachycardia, most lethal, and the one you want to prevent most often. Your cardiac biomarkers used to be called cardiac enzymes. They're made up of your CK, your CKMB, could be your LDH. That's very rarely done nowadays. In your fractions, your CK, MB I already mentioned, I think, but your LDH, 1, 2, 3, 4, and 5. Myoglobin will tell you that you have had a physiologic cause of the pain if it's elevated, but it's totally non-specific. It'll be elevated if you stub your toe or whether you're having a massive infarct. Now, the degree of elevation, of course, will change, but it's still physiologic. But it is a good indicator if it's not, if you're trying to determine if something's psychologic rather than physiologic. Troponin INT are considered cardiospecific, and they last about 5 to 10 days in the bloodstream, which is why we no longer do the LDH routinely, although it does last around 2 weeks. Hematologic studies, you're going to check your red blood cell count because you need to make sure you have enough hemoglobin to transport the oxygen that is available. So, of course, you'll do an H&H, hemoglobin and hematocrit. Your clotting studies, your proton, PTT, your INR, your coag studies. White blood cell count and platelet count will also be done. Lipid studies, you want your total cholesterol less than 200, and if you have known coronary artery disease, they like it less than 180. Triglycerides should be less than 150. Your HDL, if you're male, should be above 40. If you're female, above 50. And your LDL should be less than 100. Again, if you have known coronary artery disease, that should be less than 70. And your BNP is increased. It's your brain natriuretic peptide produced by the ventricles in the heart. That will be increased in heart failure. It should be less than 100 to be normal. And if it's over 400, you're in heart failure. So that's something that you look at. We also have our BUN and our C-reactive protein. Now your BUN in and of itself, if when it's elevated, shows you hydration. If your patient's overhydrated, it will be low. If they're dehydrated, it will be high. But your creatinine in either instance has to be normal. Your creatinine, of course, is your best measure of renal failure. If it goes up, you have renal failure. You don't need the BUN to go up for you to be in renal failure, but it usually goes along with your creatinine. Your C-reactive protein identifies an inflammatory marker, and they do feel that inflammation is the major cause of heart attack, and acute coronary syndrome. So a C-reactive protein will be done. Now, it's not cardio-specific. It will be elevated if there's any sort of inflammation in the heart, in the body, anywhere. But if it's less than 0.7, it's really not an inflammatory process, and they probably haven't had a heart attack. Your thyroid studies assess mainly your basal metabolic rate, but it's useful to know in case your heart rate is elevated. That will help there. Your chest x-ray or your digital radiography, which is what's done most often now, there's a picture of it on page 412. Remember that anything that you hear, if you hear fluid or if you hear crackles, it takes at least 24 hours for that to show up on your chest x-ray. So just because your chest x-ray is clear doesn't mean that you did not hear crackles, which is the correct term for rales. Not that you won't hear both. Your pulmonary artery catheter or central venous catheter, we'll talk about those more in a little bit, but it's mainly looking for your cardiac output and fluid levels. EKG, also called an ECG, depends on whether you're using American or British for the cardiogram portion, and your telemetry. Your EKG can be a 12 lead or an 18 lead. It could also be for the right side. It helps to identify whether or not you've had a Q or a non-Q wave MI. You can also do a Holter monitor. Your telemetry is what is done continuously at the bedside, and you probably have somebody who is, they usually monitor 2 leads at this time, not just 1. Stress testing can be on a treadmill or it can be a non-stress stress test. There's a table for this on page 417. Your echocardiogram, phonocardiogram, Doppler echo, all look at the heart, look inside the heart, and in some instances can give you a type of ejection fraction. You can also do something called an implantable loop recorder. I'm going to go back one slide. Do an implantable loop recorder. Now this is implanted for up to 14 months underneath the skin of the upper chest, under local, and it automatically records if you have a cardiac event or a change. Where the Holter monitor is on for only about 24 to 48 hours on the average. You can also do a trans-telephonic EKG. This places a box with 4 electrodes over the chest, or you can have 2 wristbands, and you can then call a phone number and you will get a 2-minute recording that's transmitted over the phone. And if you have one of the newer pacers or ICDs, they can do this over the internet. I've not seen that done, and I'm really not sure how that's done, but they do talk about it in your textbook. A TEE is a transesophageal echo. This is where they swallow a lead. The lead goes back to behind the right atrium, right ventricle, and it's mainly for dysrhythmias. You can also do a stress echo that looks at that. We've got an MRI, which is your magnetic resonance imagery that might be done. Your text refers to a box 18-8. I couldn't find it anywhere in the chapter. So if you find it, let me know. But I think they forgot it. Your nuclear medicine studies, but that's supposed to talk about contraindications for doing an MRI. That you should already know from Nursing 123. Nuclear medicine studies, thallium scan is also called a cold spot imaging. That's because the dye goes to the healthy tissue and the diseased tissue shows up black, so it's a cold spot. A MUGA scan, which is an MUGA, which is a multi-gated study, looks at the whole heart, and then it's like it keeps opening gates, opening layers, so you keep looking deeper and deeper into the heart. And this can give you an ejection fraction, and it can be done at the bedside. Cardiac cath is done for coronary artery disease diagnosis. It can be either done on the right or the left heart. If it's on the left heart, it can also give you an ejection fraction. Electrophysiology studies are done for arrhythmia diagnosis. There's a figure on page 409 that talks about placement of where that goes. Tilt table studies are done for syncope. Bedside hemodynamic studies and SVO2 monitoring we'll talk about a little bit later. Your dobutamine stress is considered a non-stress stress test. You'll start at administering 5 mics per kilo per minute, and you'll increase that to 40 to 50 micrograms per kilogram to get that heart rate up to a maximum of 85%. And that can be done in combination with nuclear medicine studies or without. But it's a way in which to stress the heart without making somebody actually walk on a treadmill. Your intravascular ultrasound is used when you have somebody who's having percutaneous angiography, and it looks at the inner layers of the blood vessels. And you've also have the intracardiac ultrasound, which is done portable, but with a handheld ultrasound piece of equipment, and can be used on multiple patients. Some of your treatment modalities, you have your intra-arterial balloon pump or counterpulsation. This is inserted into the aorta and inflated during diastole. You'll have perfusion of the coronary arteries and decreases afterload. So it increases perfusion of the coronary arteries and it decreases afterload. It can be used with people who have cardiomyopathies, who've had massive infarcts, and you're trying to help the heart rest a little bit. There are different types of pacemakers, temporary, permanent, those that are combined with an ICD, implantable cardioverter defibrillator, and we'll talk about those in lab. And you have your ventricular assist device that's oftentimes put in to maintain the patient until they can have a transplant. The different types of surgery, you have your coronary artery bypass graft. You also have your keyhole surgery, which is kind of like a laparoscopic bypass. You've got your percutaneous transluminal coronary angioplasty, and you have your heart transplant. And we'll talk about those a little bit more later on. And that finishes this first part of the first lecture. If you have questions, email me or call me or talk to me in lab. Thank you.